All right, let's get into it. Today, we're on a high-stakes mission targeting a critical topic for your USMLE Step 2 and PLAB 1 exams, intravascular hemolysis. And listen, this isn't just about memorizing some facts. It's about building diagnostic logic that is absolutely bulletproof. So let's dive right in.
You really need to burn this concept into your mind. We are not talking about a slow decline here. We're talking about a catastrophic, high-speed explosion happening right inside the blood vessels. Thinking of it as a vascular massacre, well, that really sets the right tone for the urgency and the kind of damage we're about to see. So, how do you even spot this massacre in the first place? Your first logic gate, the very first clue, is the urine. If you see a patient with dark, tea-colored urine and you check their haptoglobin and it's just vanished, plummeted to zero, that's your signal. That tells you red cells are exploding and releasing a massive hemoglobin storm directly into the bloodstream. Okay, now this slide breaks down the 3 explosion shunts that you absolutely have to master. First up, you've got G6PD deficiency, which is like an oxidative furnace failure. Then there's PNH, an invasion by the complement system. And finally, you have MAHA, which is like a brutal mechanical meat grinder, physically shredding red blood cells. Okay, before we go any deeper, here's our mandatory disclaimer. All this content is designed as a high-yield review for international medical exams. It is not and should not be taken as medical advice. Always consult official guidelines and a specialist for any clinical decisions.
All right, let's start our deep dive. First major player on the list, paroxysmal nocturnal hemoglobinuria, or PNH. The key concept I want you to remember here is the missing shield. Okay, picture this classic board vignette. A patient has that hallmark dark morning urine, a dead giveaway for hemolysis. So you run a Coombs test to check for autoimmune causes, right? But it comes back negative. Now, a lot of people might get stuck here, but that negative Coombs test, that is actually a massive clue pointing you exactly where you need to go.
This is PNH. Think of it as a complement war. What's happening is that overnight, while you're sleeping, your blood pH drops just a little bit. This tiny change is enough to activate the complement system, which is part of your immune response. Now, normally, your red blood cells have shields to protect them from this. But in PNH, those shields are gone. And this perfectly illustrates the attack sequence. It all starts with a broken GPI anchor. Think of it like the foundation that holds the shields onto the cell. With that anchor gone, the protective shields, specifically CD55 and CD59, are just missing. So the complement system sees these unprotected cells as invaders and just destroys them, causing massive intravascular hemolysis. So what's the most crucial point here? For your board exam, what is the next best step? It is not another Coombs test. It is flow cytometry. This is the test that directly looks for those cells missing the CD55 and CD59 shields. You have to lock that in. PNH means you order flow cytometry. Period. Okay, next up is our second major cause of this vascular massacre, G6PD deficiency. The way to think about this one is as a furnace failure. The cell's power plant just can't handle the heat. You see, our red blood cells are under constant attack from something called oxidative stress. To defend themselves, they need a chemical called NADPH, which is produced by the G6PD enzyme. But in G6PD deficiency, that enzyme is faulty. So when the body gets exposed to a high-yield trigger, like Fava beans, sulfa drugs, or even a bad infection, the cell just can't produce enough NADPH. The oxidative stress completely overwhelms it, and boom, it explodes. Now listen very closely, because this is probably the most common, highest-yield trap on the entire exam when it comes to hemolysis. It is all about timing.
Here's the paradox. During an acute crisis, that wave of oxidative stress has already destroyed all the old, most G6PD deficient red blood cells. They're gone. So when you run a test, the only cells left in circulation are the young ones, which naturally have higher enzyme levels. This gives you a false negative. This timeline shows the whole deception perfectly. You test during the crisis, and the lab report comes back showing a normal enzyme level, which is completely misleading. So the crucial takeaway is that you have to wait. The correct time to order the G6PD enzyme level test is 2 to 3 weeks after the acute crisis is over. So what's the right move? This slide lays out the playbook. During the acute crisis, your next best step is to check the peripheral blood smear. You're looking for those telltale signs of oxidative damage, Heinz bodies and bite cells. Then, weeks later, you order the enzyme level test to get the definitive diagnosis. Get the timing right, and you'll get to question right. Okay, we've covered the deep dives. Now it's time to lock this logic into your brain with a rapid-fire review. Let's run through the vascular matrix.
First one, you see dark morning urine, and you notice the platelet count is also low. That's a key feature. What is it?
That's PNH. And your next step is to check flow cytometry. Next up, you see bite cells on the smear, and the history mentions the patient just ate a bunch of fava beans. That's G6PD deficiency, for sure. And what's the key? Wait to check the enzyme level. Last one for this round. The smear is just full of these mechanically sheared red blood cell fragments called schistocytes. That's MHA, microangiopathic hemolytic anemia. That's the mechanical meat grinder. Your brain should immediately jump to TTP or HUS. So we've secured the logic for intravascular hemolysis, but this is just one piece of the puzzle. To truly dominate your exams, you have to connect these patterns to all the other forms of anemia, creating one unified diagnostic system. You've mastered the explosion shunts. The logic is now sealed. So the only question left is, are you ready for what comes next?